thank you for these moments to look at language in particular. There's a lot more to culture change, but it's a great place to start. And as we've looked at language, I just wanted to move into another territory, a new one. And I'll reveal it with a profound quote right here from the white paper called The Power of Language to Change Culture, which I've shared and is free and a great resource. So check this out. Putting the label therapy on normal activity has become a tradition in nursing homes and other healthcare settings in order to establish the quote professionalism of those who do it. This is a case of what is called scientism, which was developed by a gentleman named Postman in '93. And scientism is a language trend toward elevating status of an action by appropriating medical terminology. I think this is part of the institution, everyone. People do things that are, quote, therapeutic all the time without therapists because we feel better when we do them. When you go for a walk, is that physical therapy or is that exercise? Doing something you enjoy should not take on a stigma of having something wrong with you. And that's why you do it. So I would love for you to all just realize that there is a temptation in this field to elevate the status of something by giving it medical terminology. And I'd love for you to share in the chat box if anything comes to your mind, and then I'll pick it up again at the end. Thank you.
Fantastic. Thank you, Carmen. Can we have the next slide, please? So we want to move into this question of the geriatric 4Ms and to focus on the mobility, which is one of the 4Ms. So next slide, please. We have a poll here. Are we able to launch our poll? And if you're able to, please complete question 1. Gait speed as the 6th vital sign is advocated for measuring which risks? And there's one choice here. Is it falls, hospitalization, memory loss, A and C? And then what is the best evidence for reducing falls in older adults? Which intervention? So single choice. Is it core balance training? Is it deep prescription of medicines associated with falls? Is it a multidisciplinary fall team evaluation or postural perturbation training? So if you can go ahead and fill that out, that'd be great. Maybe if we're able to, we can get the poll results later after we revisit these questions at the end. Yeah, so I think the big problem with mobility in late life, and particularly in long-term care, is that you've got unresolved pain. There's an inclination towards sedentariness, in part due to fatigue. And gosh knows, post-COVID syndrome is probably exacerbating that. Certainly, we see that in our clinic. And quite honestly, we're seeing a group of patients post-COVID that are, I may have mentioned this, that look like they're drunken sailors. I mean, their gait equilibrium is just so far off. And a lot of that is compounded by this 1% loss of muscle mass that occurs yearly after the age of 60. And then other psychosocial issues that absent viva la vida, which is no mission in life. So I ask people, what do you do when you wake up in the morning? And they go, well, I get a cup of coffee. And then I said, and then what? And if they don't give a very good response, then I know that they lack that viva la vida concept. Next slide, please. And just to emphasize, falls are increasing not only in long-term care, but in the community setting by 150% over the last decade. And as the number of injuries and deaths as a result of falls have also increased. So it's an increasing problem. Next slide, please. And we can see the distribution of falls in our catchment. So if we look here at Montana, Wyoming, Utah, North Dakota, South Dakota, we've all got our fair share of falls. So we just need to realize, particularly like identifying the Dakotas, that the mortality rate from falls is almost 1.5 times more than the rest of the country. And not only that, in rural areas, the fall rate is higher with multiple injuries. So we did a small study and found that rural older adults have more head trauma and more fractured broken bones than urban dwelling older adults. Next slide, please. So the fall issue in long-term care is that while only 5% of older adults live in long-term care, 20% of the deaths occur in nursing homes. And so the average nursing home bed of 100 beds reports 100 to 200 falls annually. Up to 3/4 of the residents will fall each year for various reasons, resulting in an average of just over 2.5 falls per person. So it's a big deal. Next slide, please. I don't think we have to remind everybody of that, but these are the data. I just wanted to point out that some of our own research on falls is that we found that great variations in blood pressure were associated with frequent fallers. You know, these people are falling 6 to 10 times in 1 year. They had widely different blood pressures from month to month, and we think that that's due to poor soft tissue compliance. You know, the high blood pressure variability is linked to very stiff blood vessels. And so we think the stiffness of musculature, tendons, and ligaments also contribute as a risk factor for falls. Next slide, please. So the age-friendly concept of mobility has the goals of older adults moving safely. We would like them, if possible, improve their function. So all of this can help support what matters to the older adult. Next slide. So the first thing is to assess fall risk, and I think each of us do this in long-term care, either commonly or have some unique features that we can use to assess fall. And we also do the activities of daily living, as part of the MDS, to look for functional impairment. So functional impairment is a fall risk parameter, and in recognizing the high fall risk of just about everybody in long-term care, we need to have some management plans that include efforts to reduce sedentary time, environmental safety concerns. I mean, there have been times when I've gone into a nursing home residence room and found debris all over the place, like there was spilt water. In fact, one of our nurse associates slipped on some water and broke her hip at the ripe age of 55. So yeah, I mean, it's just environmental factors, and then what commitments there are to increasing their function and their functional strength. So I was astounded when I first started working in long-term care that most of the residents that were admitted over the age of 65 could barely lift 5 pounds, and so that's fine. So you identify what their baseline is, but you know what? At the end of 6 weeks after or their 100-day benefit or whatever, they still were only lifting 5 pounds. And so what was it about their lack of progress that made a difference? And I just not to toot my horn, but we published a paper looking at whether the type of insurance made any difference in recovery, from rehab. And somewhat surprisingly, Medicare didn't do too well compared to commercial insurance. And that's not an indictment of Medicare. Medicare is wonderful, but just the methodology of rehab through the type of insurance seemed to have some association with different outcomes. Next slide, please. So in terms of mobility, we want to create a safe home for the residents in long-term care. We want to hopefully identify a daily mobility goal. If that's just simply standing up and out of your chair while watching TV during commercials, that's part of the mobility plan. And then, as I mentioned about the 5 pounds going no further than 5 pounds after 100 days, that's the whole issue of monitoring progress. Good. Next slide, please. In terms of mobility assessment, a couple of things to think about, for evaluation. If you have somebody that's a faller, check for orthostasis for sure after each fall if there's no injury. Think about postprandial orthostasis. There's usually these frail older women the ones that kind of could be picked up by North Dakota winds. Those typically 30 to 60 minutes may be the type of people that have a very low blood pressure after eating. So getting a blood pressure 30 minutes after eating the large meal of the day would be a good assessment. There's new evidence that getting rid of the bifocals or the progressives helps reduce falls. Checking for beeswax, making sure they have good hearing, reduces falls by 1%, and it improves the cognitive status by 1 full mini mental status point, which is, I find, kind of intriguing. Look for weakness, and again, focusing on leg strengthening exercises. Check for cogwheeling, which may show early Parkinson's disease. Check the feet for sensory changes. There's some evidence that using those nubs, those non-skid socks in a good pair of shoes might help improve the neuropathy sensation of balance. And then also check for pain. A lot of times you end up empirically treating Alzheimer's patients with Tylenol, 1,000 milligrams twice a day for undetected pain or unexpressed pain. And sometimes that also helps with fall, or I shouldn't say no evidence, but it may help with your fall prevention program. And that, by the way, would be a PIP. So that if you have a unit, a memory care unit, and you have X number of falls per month, that you give a trial of 2 weeks, for example, of scheduled Tylenol, and seeing if that reduces the falls. That would be a PIP. Good. Next slide, please. Some of the red flags that we need to worry about with falls: if there's osteoporosis, if there's a profound weakness, loss of bowel or bladder control, and also in face of fever or a drop in body temperature. Next slide, please. So to do a fall risk assessment, one is the Sharp and Romberg, where you have the person stand with 1 foot in front of the other and try and hold that balance. You're there ready to catch them in case they fall. If they can't hold that for 30 seconds, and usually if they can't hold it, it's within the first 10 seconds. The other way to measure fall risk is by gait speed. So these are people that can ambulate with or without a walker or a cane. But anything that's less than 1 meter per second is considered a high fall risk. Others will use the timed up and go test. It's very similar. You have the person walk out 10 feet and walk back. If it's greater than 11 seconds, then they have a fall risk. And then the therapists typically use the Berg scale, which I forget the exact number. I think it's 55 is the best score. And the lower the score, the higher the fall risk. And that's actually a way to measure serially over time. You can do the Berg scale and come up with a score and see if your therapy has improved the Berg scale. So that's what we use in our fall clinic for measuring progress. Next slide, please. So one of the questions is, how can you improve mobility? This is separate from trying to reduce falls, because mobility is an important element towards overall health. One way is to measure the steps, and depending upon the frailty versus non-frail, so for a healthy adult, it's 7,500 steps per day, which basically is 3.5 to 4 miles. You don't have to do that all at once. You want to minimally have twice weekly resistance training, both upper extremity and lower extremity. And if it turns out that they can't do lower extremity resistance training, whatever they do for upper extremity has equal benefit. So that's an important concept. And then we often overlook the fact that older adults need 1.5 grams of protein per kilogram daily. And that's usually around 60 to 90 grams of protein, depending upon their body size. In long-term care, regular vitamin D supplementation has been proven to reduce falls. And so as a policy, your facility should have 800 to 1,000 units of vitamin D daily. for each resident who doesn't have a contraindication to it. And then, the whole concept of, self-efficacy. So getting older adults, older residents to stand-ups and sit-downs during commercial, breaks, or just doing their stretchy bands on their own. And certainly group sessions help with reinforce that concept. Next slide, please. So a lot of people will say, it's cold outside, so I can't really walk. Well, stepping in place counts and is as effective. Actually, if you have a walking program with walking sticks, those Nordic sticks, those really are even more beneficial. There's programs called, like a Walk a Pet program. I mentioned about stand-up sit-downs during TV commercials. Other ideas include Senior Olympics, and again, they could be just upper extremity focused as well as lower extremity activities. I don't know if you can put into the chat box whether you've used Xbox Exergames. That's another opportunity exercise. And as I mentioned, the upper extremity exercises benefit body-wide physiology. Okay, next slide, please. I alluded to this question of pain control. So twice daily acetaminophen sometimes can be of benefit, for improving mobility. You may have heard this from me before. I'm a huge proponent of using turmeric at anti-inflammatory doses. So 1,500 milligrams of turmeric twice a day is the starting dose. You can go up higher to up to 4 grams a day. But basically, turmeric has been demonstrated to reduce osteoarthritic pain of the knees, comparable to regular dose Motrin or nonsteroidal anti-inflammatories. You can use things like manual medicine or muscle energy techniques to stretch muscles. I find a lot of patients in our fall clinic have poor mobility of their psoas stretch, and so they don't have good hip extension. And so even getting therapy involved in that to do a program of hip extension exercises. You can do those yourself and with your residents by putting one foot in front of the other and taking the arm that's opposite of the foot forward and bringing that over your head. And that'll help with that kind of stretching technique. Other types of pain control. The first pain control for localized joint pain, sorry for the tongue twister, is Voltaren gel. So unless it's not contraindicated, using mentholated icy hot or something equivalent, plus or minus Voltaren gel is the way to go, using topical therapy to reduce pain. Next slide, please. Families and volunteers, helping with a daily mobility log. There's remote monitoring now. There's a company here in North Dakota that's producing rolling walker pedometers. So, and it sends a signal to somebody who's in charge of that, and to make sure that their either loved one or older adult relative is walking on a regular basis. There's also the concept of team competition, and got to be a little bit careful with that because sometimes the family members get a little too rambunctious, and so you don't want any speed-related events. It's more quality, not quantity per se. Next slide, please. In terms of prevention, just remember that question. It's multidisciplinary teams are the primary evidence-based intervention for falls. So these teams usually consist of a PharmD, physical therapist, a provider, usually a geriatrician if possible, otherwise a nurse practitioner or physician. You also want to do environmental check. So a lot of times residents have their dwelling in the facility sort of discombobulated. A lot of times I'll see that they don't have their eyeglasses properly cleaned. I mean, when I do medical rounds in a visits, clinical visits in a long-term care facility, I'm always asking to look at their glasses, whether one, they can get them, and then two, whether they're clean, and I can't tell you how much Smirnoff you see on these lenses. And then importantly, get a resistance training program. Do that even before you do the walking program. And then flexibility, not firm evidence, but possibly related to, again, gait and stability. So we address that also. Next slide, please. And then additional ideas is to, like as I mentioned, having a standing order for vitamin D supplementation, getting rid of all those medications that can cause falls, either reducing the SSRIs, certainly the antipsychotics, certainly the opioids, all of these. And you know what? I mean, something like turmeric, if they're not on anticoagulants, they can take turmeric as an opioid sparing supplement, and it's natural medicine. It's not opioids that are constipating them and causing all sorts of memory loss. And again, employing staff and volunteers to help with the older adult doing these sit-stand exercises, as well as standing on one leg under supervision for core balance training, and to educate the family on that. They can be part of this process. I put down perturbation training. That's where you catch the medicine ball. That has to be under supervision with physical therapy. Next slide, please. And then importantly, you want to track the progress. So, making a log, for the older adult to check how they do and whether they perform and improve either in a 400-meter walk, 6-minute walk. You could do that maybe every other month and track their progress. Next slide, please. And these slides are all going to be available. So here you go. Here's a PIP on mobility. If anybody was lacking ideas, I'm sure you're not, but here you go. You could look at the supplementation of a standing vitamin D order and see if that changes the monthly fall rate as an example. So again, these are all ideas for you that you can contribute to your fall reduction program. Next slide, please. Okay, so that's kind of wraps up my session here. Let's go ahead and launch the post-knowledge poll, and we'll move on into our next topic for QAPI. So same questions as before. Gait speed is a 6 vital sign, is advocating which of these choices? And then the second question is, the best evidence for reducing falls in older adults is, and I just mentioned what that answer was, so. Okay, so I think we can move on to the next topic here. Appreciate everybody's attention. And we can take questions at the end here of the session if we have time.
Would you like me to share the results when we hit about 50% participation, or move on?
Yeah, why don't we move on, because I'm just looking at the time here. We're pretty much getting close to, halfway point. Thanks, Chris. Okay, yeah, so just our conclusion. Mobility plans are important for improving function, as well as for chronic disease management. You get better sleep hygiene, you get better blood pressure control, and you can avoid a lot of this polypharmacy if you just get pretty decent mobility plans. And it's important to monitor progress. And then finally, all those ideas that I provided for program improvement around a mobility plan and fall reduction. Next slide, please. Okay, I'd like to hand this off to our quality improvement officers or agents, mentors. So Barb, are you ready?
There we go. I was trying to unmute myself. Can you hear me?
We can, yeah, thank you.
Okay, great. So first of all, I just want to say thank you to you, Dr. Jurevich, and to Carmen. I wish I joined this series at the beginning. I've learned a lot and I have really appreciated. So thank you for hosting me today. I'm going to talk about step 11, which is getting to the root of the problem. And this is step 11 out of 12, following the CMS model for CWOPI. So Chris, you're going to advance the slides. Okay, perfect. Thank you. So follow up from last week's session, checking out the building blocks and resources, including CWOPI at a glance, kind of a recurring theme here. And then with each other, all of you working directly in long-term cares, share your success stories and your visions. Please tell us how you're doing. Thank you. Next slide. Okay, so this is our pre-CWOPI poll. I think many of you already know the answer, but the question is, getting to the root of any problem or opportunity is key, because what seems like a simple issue could involve many dynamics, true or false, and then we'll circle back to that at the end of the presentation. Okay. So, you know, a little bit about me. I am a licensed nursing home administrator. I've done a lot of hospital co-located nursing home work for many years, and spent the last 6 years doing directly being a nursing home administrator, and have a pretty strong quality background. So when I was asked to perhaps present this, I thought, oh, I'd love to do that because of a strong quality background. And when we talk about doing an RCA, or root cause analysis, what we're really talking about is getting to the root of the problem. So as leaders, I think when something happens, it's natural inclination for all of us to say, oh, I know why that happened, or I have a theory, or, you know, I've always done it, you know, I tend to think I know what the issue is, but by doing an RCA, we really get to the root of the problem. And the problem is rarely people, it's almost always process and communication. So next slide. Okay, so kind of in a nutshell, root cause analysis, it describes a systematic process of identifying contributing causal factors that underlie variations in the performance of the care delivery, the things that we do every day taking care of people. It's a structured method of analysis. It's designed to get to the underlying root cause of a problem, an issue, you know, what happened, and it leads to identification of effective interventions, and not only for making improvements, but the idea when you do a root cause analysis, especially where you've had harm occur, the goal is to improve your processes so that particular harm event will never happen again. Okay, next slide. Okay, I just noticed that the slides are numbered according to the sequence for our series. I was going to bring in, I believe, at this particular slide, and I'll go through this, and then I want to introduce someone to you who's going to co-present with me today. So in my career, I've done a lot of root cause analysis, a lot on the hospital side of the fence, and participated in the nursing home side. And I think the most important thing to understand about root cause analysis is to ask what's called the 5 whys. And sometimes there's 10 whys, but you start drilling down, and by the time you've finished asking the question, you get to the root cause of the problem. And once you have the problem defined, you can work on the process improvement. So I've always used this analysis. This is something I created about 15 years ago. And it's, you know, the question is, oh, Mike was late for work today. Again, how come Mike was late for work? Well, we think we know the answer. He's lazy. He didn't get up when his alarm went off. He doesn't think his job's important. He's whatever, right? Okay, well, he was late today because his car ran out of gas. So then you say, well, how could he let his car run out of gas? Well, in this case, he didn't check the fuel gauge. Well, how can you not check the fuel gauge? Everybody knows you have to put gas in a car, or you have to plug your car in, right? So he didn't check the fuel gauge because he was tired. Well, what the heck? Why was he tired? Well, he was tired because he was up all night with the baby. And why was he up all night with the baby? Because the baby was sick, and he was caring for her fever. So, and you could keep going down from there. It's a very silly and simple analysis, but it illustrates the idea of the 5 whys. So let's go to the next slide. Okay, so this is where I would like to introduce Sophia Ness. And Sophia is going to talk with us. There she is. Hi, Sophia.
Hello.
She's going to talk with us for an RCA process that she did in her nursing home. And Sophia, you're the director of nurses at which facility, would you tell us?
Westwood Heights in Lander.
Okay, perfect. Well, thank you so much for joining me. Why don't you talk about the RCA that you did,
Okay.
please?
Well, first of all, thank you for having me here, and I'm super excited to share, what I have learned and what I have tried in the last couple of months, and it's still in a work in progress and stuff. So one thing for sure that we're working on right now is, of course, like our fall. So our fall rate is super high and stuff, and then we, of course, as a leader, we want to see like what is going on our building, and we kind of track down and kind of figure out the trends. When is the fall happen the most? And and of course we talk about the 5 why all this happen and such. So when we do that, we found out that most of our fall, will happen during like a early time, like early hour, between from 4 a.m. to like about 7 a.m. and stuff. So we kind of look into all of that, and then we start kind of looking into it more, talking to our team member. And things. So one thing that we focusing on right now, after we talk and look into the fall stuff and what lead to that fall, one is sleep, the sleep, because, prior to this, this project been doing for like almost 2 months now. So about 2 months ago. So our culture here at Westwood Heights is that everybody gonna be, get changed and repositioning every 2 hours. Because that is our expectation, that is our culture. It doesn't matter the resident, need change or not. This is the expectation. So regardless, they're gonna be waking up, to do the round checking and all that stuff. So and then on top of that, the staff is like getting so stressed out because they have a time limit. Like, I have to put resident to bed at this time. This is my responsible as an evening shift working from 2 to 10. If I don't lay them all down, I don't finish my job, or the night shift, I'm employee feel like if the evening shift don't, when they come on to work and the residents still awake, the previous shift have not completed their tasks yet and stuff like that, so that was our culture and stuff. And again, we're working on all of that. So the sleep, thing, so we're working on a good night's sleep. That's what we're working on right now. So what we have been doing, we have putting out the elimination record, like a pattern kind of deal. So we do it very slowly because we want the most accurate data, from our employees and the resident, of course. We don't want to overwhelm them. So we started on one hallway because we want to see their pattern. Like, when do they go to the bathroom? When do they need change? When do they need the repositioning? And those sort of things, and on top of that, talk to the residents, because some residents still can tell us like, do not wake me up during this time, let me sleep, wake me up on this time and such, so we have been creating a more individualized care plan, to promote a good night's sleep, pretty much. So we did that, and also we put out a sleep pattern record as well. So again, kind of know, what time these residents awake, what time they like to go to sleep, and so on and so forth. So that has been, going really well on that one hall, so when we get all our, point and our data and stuff, we talk to some staff, and then also the resident who can tell us and we able to update and make their care plan is more individualized based on what resident need. So far on that one particular hall, you know, the resident is more awake. You know, the fall have decreased, knock on wood. It really has been really decreased, the fall. And I'm super, super happy about that, because I mean, that was so huge, especially, you know, the past couple of years during the pandemic and all that stuff, you know, the lockdown and such. So, you know, it has been working really well. And so right now we're moving on to, we have like 4 hallway in our building. So we're going, you know, on the second hall right now. But the one thing that we're gonna do a little bit more different on this second hallway, is we're gonna get resident and family more involved, you know, because we do have some newer residents that we don't know much about them, or the resident cannot really tell us, like, you know, their sleep pattern or answer any question like that. So we're gonna more like a collaborative team, you know, effort to create a better, like a good night's sleep for our residents without interrupting them, you know, so many times every 2 hours and stuff. And then, you know, on top of the fall thing, because, you know, we wake them up to go to, you know, or change or check them or whatever it is at 2 o'clock in the morning. And now we tell them, well, go ahead and go back to sleep. Well, they're not going to go back to sleep, you know, or sometimes we just lay them down after dinner because we feel like it is time to go to bed, because I only here till 10 o'clock. So I only have 4 more hours on my shift, and this is part of my task. I have to lay you down. So, you know, when they go to bed at 6 and now it's 2 o'clock, we wake them up to change, that's 6 hours they already been asleep. So they're not going to go back to sleep, you know, so we tell them go back to sleep. And then now they're going to cry out bed, and that's what leads to the fall, you know. And on top of that, I mean, like, you know, I've been doing it for, like, say, almost 2 months or over 2 months now. And then we look into our psychotropic medication use, you know, the sleeping aid medication. Like, we keep prescribing all those things because our residents wake up at 2 in the morning and we say they're not going back to sleep. But we don't think, like, well, they already been sleeping since 6, you know, that's already been 8 hours. Like, how many hours do we expect our residents to be in bed? And, you know, so stuff like that. So that has been, you know, going really well. Staff education, a lot of team members very involved in this, you know, new culture changes in our buildings. Resident is able to be more awake during the daytime. They, you know, go to activity, they more engaged, they eating better. They just overall just really like a lot happier and stuff, you know. So, and of course our staff, you know, it's less work for them. So therefore, it's also help with that, you know, staff retention on top of that as well. And so, you know, I think just overall, it has been very successful. So we are keep going until we are pretty much, you know, done for the whole building. And then we just make change as we go. But so far, everything is going really well. Even from a, you know, resident who can tell us, family member, employees, you know, we see all this positive outcome around the, you know, the whole process. So.
Yeah, that's excellent. Sophia, thank you so much for that presentation. And if anyone has any questions at this point, let's just put them into chat and then we'll take them at the end. I really appreciate what Sophia had to say. I know several years ago, one of the ways we thought we could reduce falls was purposeful rounding, which at the beginning, at least for some of us, included waking someone up to toilet them. And we now know that that really is a very bad idea. And I don't think people are really doing that anymore. So at least at nighttime or whatever time that person it is their, you know, preference for sleep. So anyway, thank you, Sophia. We have just a couple more slides talking a little bit more about RCA, getting to the root of the problem. In your homes, think about choosing actions that are tightly linked to root causes and that lead to system or process change. And these are usually considered to have higher likelihood of being effective, you know, kind of holding the gains. Avoid quick fixes and weak actions. Avoiding these are really important in achieving your goals. And then, you know, the most important thing to me with root cause analysis and all process improvement is to, you know, engage your stakeholders, make them part of the solution. housekeeping is every bit as important as the RN in many cases. So encourage active participation. RCAs can be really intimidating, especially if you're doing a formal RCA for resident harm. It can be really, really intimidating to staff, especially if they've never participated before. Leadership sets the stage for safety. It's important. And something that I have said over and over and over again is that root cause analysis is focusing on systems and processes, not individual performance. So as many of you leaders know, if you're doing any kind of physician or nurse peer review, there is a time and a place for focusing on individual errors, and it's separate from your broad scale root cause analysis. So once people understand that it's not about what someone did wrong, it's about figuring out what are our processes that contributed to this, and how can we better support our teams as they deliver the care, not individual performance. Okay, next slide. Oh, sorry. And this is almost the last slide. So I just want to say that leading and conducting effective RCAs takes a lot of practice. Areas to consider to becoming more familiar. The Joint Commission is really an excellent resource. They have white papers and toolkits and all kinds of good stuff around conducting RCAs. Build RCA examples into your staff education and training so that even if someone's never participated, they understand that they might be called because their voice is important. And then use your RCA techniques for adverse events and discuss the technique with the team. So there is a difference between process improvement, PIPs, and doing RCAs, but I will tell you that CMS now really expects to see RCAs, especially where there's resident harm. A facility I was with a few years ago had a fire door that had malfunctioned, and we didn't realize it until a surveyor found it. But because we did an immediate RCA and fix it, of course, but we did an immediate RCA on what our gaps were that allowed us to get to a point that we had a fire door that couldn't be opened. We avoided an immediate jeopardy in that facility. So RCAs are something that CMS really expects, and surveyors really like to see. They want to know that you conducted an RCA when there's potential for harm. Okay, next slide. And we're back to okay, and so Chris, do you want to call it when you think you've gotten enough responses? Perfect. I think most of you knew the answer to that one already anyway. So thanks for all the good work you're doing. The last thing is the homework slide. And then just something to think about, identify if RCA is in use at your home, and come prepared to show any successes in conducting an RCA, perhaps at the next meeting, which I think may be the last meeting. So perfect. Okay, thank you, everyone. Appreciate your time and attention today.
Great, thank you, Barb. And by the way, I responded to your question about the socks with the nubs. They're meant to be worn with shoes, not shoes. So
thank you.
Yeah, that comes from Australia study there. So Carmen, do you want to continue on with our culture change?
Here we go. So I want to continue this idea, everyone, of the medical terminology with another quote. Look at the word therapy, for instance. Why does everything have to be therapy once you live in a nursing home? If I like to paint before I moved in and I paint now, why is my hobby art therapy? I mean no insults, none, and everybody to the wonderful folks who are therapists and their work, their special training, or their skills. In fact, I'm a massage therapist myself, but in this context, therapy is another one of those separating words. So next slide, please. This is just a challenge for all of us. I'd like y'all to think about this. Why? Why did we feel like we had to call drawing and painting art therapy? You know, in your real life, do you say, I got to go home and get some music therapy, or do you just go listen to your music? We all love our music. How many of you have animals? Did you know it's a statistic that 60% of us have animals at home? And why in the nursing home is it pet therapy? Even the essential oils has been named aromatherapy. I do come from the field of activities, and we felt a pressure to not just call them activities, but why do you suppose we started to call them therapeutic activities? To see the pressure to become more medical. Next slide, please. And so notice the word patient. Where does it come from? Hospital. A more normal word, normal life, is just referring to people. Person, individual. We have this word intervention. It's very medical. No offense, nurses, it comes from nursing school. It's okay. It belongs in a medical context. But in real life, could it be that what we mean is approaches? You take different approaches with different people and it's softer. And even individualized approach is even better. It reminds us that that's what it's supposed to be. Molly brought up dietary. Notice, is that normal or is that institutional? Is that medical? We even say, I gotta go on the floor. Bye, I gotta go up on the floor. And worse yet, we call people frontline. That's not even medical, everybody. That's war and it's combat. And we don't have to use those words. I think we need direct care and hands-on. I'll take the next slide, please. So I just found it interesting in this context, everyone, of de-prescribing. Notice how we're actually trying to do more prescribing. And what I mean here is, here comes some more medical lingo. As a co-editor of an international journal, I see a lot of research, and guess what? There it is. We're prescribing social care now. We're giving dosage for exercise. We're doing social prescriptions. And I kind of get it. I kind of want to do it myself, but I can't. I can't succumb to medicalizing life. I'd love for you to think about that. So if we didn't say it, I think what we mean is we're making recommendations and suggestions. We're finding out people's preferences, maybe a plan. And it just so happens, it came out this weekend. Our next editorial, look at the title, Promising Practices for Social Connectedness, Fall Prevention, how timely, and Improved Cognition. Should social care be prescribed? Should life be medicalized? And so I'm only, ringing the bell for attention for all of us to think about, is this really where we want to go? And so Taya, can I ask you, I think you'll be okay with this question if you can come back. So Taya avoided a word. You did a great job, so Taya. Can you tell everyone what you avoided and why? We didn't practice this, everyone. We're in a culture change project together. Go ahead.
Yeah, so instead of say like the good night's sleep, my actually first, when I be doing the project to do the following stuff, is I said, a sleep hygiene, right? So and then when me and Carmen talk and stuff, and and talk about the terminology and things like that, and and sometimes I don't think stuff like that. I go to nursing school. It is what I was taught. Use this fancy big word and stuff because make you feel like really special, I guess, in a way.
Yeah.
But sometimes not realizing, what about other team member? What about the residents? What about family member? Even to your nurse, like, not everyone have that, the same, I guess, understanding or whatever, with this terminology and stuff. So I do like that good night sleep much better because that makes sense to everybody. And it also does help the staff, especially like my CNAO on the floor, understand why we need to do this sort of thing to make this change, for the resident, because sleep hygiene can mean many things.
That's right. Thank you, Satya, so much. So everyone, just for fun, the other day I said to my husband, sleep hygiene. He goes, what? I said, sleep hygiene. What the? I won't tell you what else he said. And then I said, what do you think that means? You know what he said? Go to sleep and brush your teeth. See, it makes the point, right? I'll take the next slide, please. We have this opportunity, everyone, to change language to be normal and to make sure everyone knows what we're talking about. That's the cool thing. Isn't it cool to think about what do you need for a good night's sleep? That's what we mean by sleep hygiene. But when we say it, even I don't really know what that means. I didn't go to nursing school, see, and it begs that there might be confusion. And so just a little recap, last time we're trying to move away from labels. This is a person who has diabetes instead of the diabetic. You know, it's a person who's falling a lot instead of the frequent faller. You know, we use people's names. We try to avoid the room number, the diagnoses, etc. I'll take the next slide. And again, just quick reminders, person, individual, neighbor instead of patient, home and community. Maybe try that instead of facility, neighborhood instead of units, team instead of department, team member instead of staff, checking in or check-ins instead of the medical terminology of rounding. And I think I talked a lot about most of them. Actually, Molly brought up admission and discharge is very hospital. People move in and out or come for a stay. Oh, and here's a good one. How many of you say, excuse me, I'll be right back. I'm going to go toilet myself. We can get rid of the word toilet, everyone, and toileting. Thank you